Hi, my name is Karl Barbaro and I and my co-author James Midgley have recently published a paper in Musculoskeletal Science and Practice titled Priapism, a symptom of claudication of the cauda equina in spinal stenosis. In this paper we discuss the rare clinical presentation of priapism in patients with spinal stenosis. As authors, we're aware that this presentation and clinical features may not be new to some readers. However, it was something that neither of us had come across clinically. We therefore completed a structured narrative review of the literature in an attempt to understand the pathophysiology and potential causal relationships of priapism in the context of spinal stenosis and cauda equina syndrome. Our findings were mainly single case reports or small case series which were analysed, and we decided to publish to share our learning. So a brief overview is that priapism is a prolonged erection unrelated to sexual stimulation. This can occur in patients with spinal stenosis. The physiology of penile erection is complex. However, it seems that in patients with stenosis, the increased intrathecal pressure secondary to direct compression or local nerve root ischemia at a stenotic level of the cauda equina can lead to parasympathetic hyperactivity and subsequently priapism. From the cases we found, there seemed to be an association with walking. This would suggest that there's increased mechanical pressure on the cauda equina induced by walking in patients with spinal stenosis, and that may therefore contribute to priapism as a transient autonomic disorder. As highlighted in the papers, the probability of a patient with cauda equina syndrome progressing and to what speed and to what extent is unknown. This seems to also relate to priapism. It's not clear whether patients with priapism are more likely to progress to an acute cauda equina syndrome. However, early recognition and contextualisation of the symptom in line with their overall presentation is integral for safe patient management. Although it's transient, the manifestation of priapism suggests that the patient has experienced sexual dysfunction from cauda equina compression, and patients should be appropriately safety netted and managed depending upon their overall clinical picture. It's therefore a pertinent symptom to be mindful of whilst assessing patients with low back pain. The primary literature appears to demonstrate decompressive surgery as a viable treatment option for the subgroup of patients, and the improvement in the symptom post-operatively suggests there is a causal link between cauda equina compression and priapism. However, on reviewing each case, some patients did have symptoms that may have been suggestive of an incomplete cauda equina syndrome. Therefore, patients with stenosis who progress to develop symptoms of cauda equina syndrome, they may experience priapism as a potential manifestation of CAS. As I mentioned initially, our aim was to share our learning in the hope that it's a useful addition to the evidence base. Thanks for watching.